all of you. Today, in our expert opinion, one-to-one interaction with KOL. We have with us an expert, Dr. Hammad Momin, who is an intervention cardiologist from Bhiwandi, Mumbai, Maharashtra, India. There are some KOLs you don't need introduction, but still for the benefits of doctors who would be listening to sir's expert views and recording in later days, it is my duty to introduce him to the group. So Dr. Hamad Momin is a highly accomplished intervention cardiologist with more than 16 plus years of experience in complex coronary intervention, cath lab leadership, and in advanced cardiac care. Also, Doctor is the director of HSM and dhange Cath Lab Bhiwandi, the first dedicated cath lab which has completed more than 1,000 plus cases in approximately 2 years. Many of his achievements are there, and a few of the key achievements which I would like to share it to the audience is two of his scientific papers have been accepted and presented in SKY 2016 Annual Scientific Conference, Orlando, USA. Doctor has also done, along with his intervention cardiology, he has done FSI USA, which is a certification. Plus, is a member in all the major cardiology societies of our country. That shows that doctor, besides being into professional acumen, he has also spent a lot of time in his academic leadership. Sir, it's our privilege and welcome you once again to this one-to-one interactive session, sir. As I have communicated, sir, this session gets recorded. The purpose of this recording is, sir, your expert view and comments in the field of cardiology, which I would be putting forward as few questions, sir. We would like to get your expert opinion. The same gets which gets recorded will be utilized for further improvement and scientific purpose for the junior upcoming student cardios and PGs, sir. With your kind permission, sir, I'll get into today's session. What we have done is, sir, we have got 6 to 7 subtopics in cardiology. I might be asking you one or two questions into each of this therapeutic area, and we would like to seek your opinion about the same, sir. With your kind permission, should I start the session, sir?
Yeah, sure.
Yes.
Thanks for the nice introduction. It's a pleasure to interact with you.
Yes.
So we can go ahead.
Yes, sir. Thank you, sir. Sir, my name is J. Vignesh. I handle the marketing of microcardiology division under the as designated as Vice President Marketing, sir. With that, sir, the first session, which is most important one, is, sir, on antiplatelet therapy. Sir, when you select between antiplatelets like ticagrelor, prasugrel, and clopidogrel for your patients with post-PCA, sir, what is your practical decision framework? And this decision framework is, does this differ from what guidelines normally recommended for their use, sir?
See, it is purely scientific based what we practice, and it depends from patient to patient. When a patient undergoes PCI, that is angioplasty, they go for a different reason. Like suppose a patient present with ACS and undergoes PCI, then the choice and the duration of drug is different. When there is a stable coronary artery disease patient who has angina on exertion and we do PCI and that, then the choice of antiplatelet and duration is different. So mainly in acute coronary syndrome, whether it is unstable angina, non-STEMI or STEM, whenever we do angioplasty, that is PCI, as an evidence-based ticagrelor is the preferred drug. It is the preferred one for its benefits and also safety profile. So, and the duration for ACS patient, the duration is for 1 year, the dual antiplatelets, and then we switch to a single antiplatelet with statin. Now comes to stable coronary artery disease patient and undergoes PCI. Again, the preferred drug is the second drug is ticagrelor, but the duration is up to 6 months. Then we switch to a single antiplatelet with statin. Now about clopidogrel. Clopidogrel, where it comes in a role whenever there is a high bleeding risk, when there is an elderly patient more than 75. In those subset, we prefer clopidogrel. And about prasugrel, we have to remember about prasugrel is that the prasugrel is only indicated when the angio is done and we know that we are going ahead with the angioplasty. So at that time, it is indicated, and especially in younger patients whose weight is more than 60 and age is less than 75, and there is no history of stroke, prior stroke. Though this is the thing. So prasugrel in a selected younger patient, and sometimes we switch from tika to prasugrel, whoever is not tolerating ticagrelor in because of dyspnea or other issues.
Right. Thank you very much. So thanks for that vivid reply about the usage of antiplatelets in your practice, sir. With this in background, I move on to the next subtherapy, that is anticoagulation, sir.
Mm.
Sir, how do you manage anticoagulation in CKD patients with atrial fibrillation? And up to what EFGR do you switch strategies or avoid specific agent? And what is your preferred NOACs in these patients?
See, just you are asking for a triple therapy or just for atrial fibrillation you are
Just
asking?
for atrial fibrillation
Oh,
patient with CKD.
okay. So, in case of like a non-valvular atrial fibrillation, the NOACs is the preferred one. If it comes to a RHD with mitral stenosis with atrial fibrillation or MVR with atrial fibrillation, then vitamin K antagonist comes in. Now, about non-valvular atrial fibrillation, the my preferred agent is apixaban. Apixaban. And there are guidelines that which says that if the patient's creat is more than 1.5, the patient age is more than 75, if the patient weight is less than 60. So we preferred apixaban 2.5 milligram BD. But up to 30 GFR or 45 GFR, we can safely go ahead with apixaban. Even rivaroxaban comes in, but I prefer apixaban.
Thank you, sir. Thanks, sir. With this in background, let me move on to the third category, that is lipid-lowering agents, sir.
Yeah.
Sir, how aggressively do you target LDL cholesterol in your, again, post-PCI patients, sir? And up to what LDL level you realistically want your patient to achieve, sir, in your practice versus guideline recommended targets? Because why I use the word guideline recommended targets, sir? Today, guidelines talks about bringing LDL less than 55 milligram. And
Yeah.
recently, LAI, Lipid Association of India, talking about in a very high risk patient to bring it less than 36 milligram per deciliter. But
Yeah.
you will have a realistic goal which you feel that my patient should carry. If they reach to this LDL cholesterol level target, I think I am okay to maintain it that level. So what is your viewpoint, sir?
You rightly mentioned that ACC guideline, it recommends LDL less than 55 for a secondary prevention. And for a primary prevention and high residual risk, again, it is less than 55. Whereas Lipid Association of India has a more aggressive targets because as an Indian, what we have seen that generally the LDL level as compared to Western, we have a lower LDL level. There is almost difference of 10. So target is also aggressive. Target is also, we have to go a bit lower. And in Indian subset, we have seen that lipoprotein little a, the incidence is also high as compared to Western population. So LDL target is very aggressive as per Lipid Association of India. I have met Dr. Raman Puri, the president of Lipid
Right.
Association of India, and have also discussed with him in one of the conference. And uh, so what uh, they say, Lipid Association of India, that you can go as low as even 15 for a refractory recurrent event, extremely high risk category B. And in category A, they have recommended up to 30. But in realistic world, what I target is less than, at least less than 55 milligram per deciliter.
Okay,
At
sir.
least.
Okay.
And I have discussed him with personally, his one patient was on 15 or 18, but he was not having any cognitive impairment, or we are worried about some hemorrhage in brain. So, but his patient was absolutely fine, up to level of 18 also, milligram per deciliter.
Okay, sir. But in your patient, you are comfortable up to even patient less than 55, you believe
Yeah,
that?
I'm comfortable, but
Hmm.
I try to go more further, but I'm comfortable with 55.
0.5, which is a guideline recommended value.
Yeah, ACC guideline, the recent 2026
Yes,
guidelines.
absolutely, sir. Sir, what triggered my this particular question to you, sir? What typically activates the addition of acetyl in your practice, sir? Is it number one, LDL non-goal achievement on maximum tolerated dosage of statin, or the patient is having statin intolerance, or an early add-on in an high-risk baseline risk patient? So how do you
What
believe
you
this, sir?
mentioned, I have preferred in all the three. What
Okay.
strategy what strategy we follow is the addition of azithromycin earlier, because as an Indian we have a high residual risk. We are diabetic and central obesity, so we have high
Mm,
residual risk. So hit early, hit hard.
okay.
So in all ACS patient, in all PCI patient, we add high dose statin with azithromycin at the time of presentation only.
Oh, okay.
So, first thing, so we achieve the LDL goal much faster and the target what we wanted. Then, definitely, whenever there is a statin intolerance or a statin associated muscle symptoms, so we can decrease the dose of statin and we can add a azithromycin.
Okay, sir.
That is the
Second,
second
second
one.
category. Yes, sir.
Second category. And also, when we need a moderate, when we need a moderate intensity statin to reduce the dose to a certain level, so we add a low dose of statin plus azithromycin. So with statin, azithromycin is my go-to drug. I always prefer a combination which is available.
Which is the estimate. Great, sir. Thank you, sir. There is one more category, that is patients who are having high triglyceride levels, sir,
Mhm.
in spite of using maximum dose of statin. Sir, how do you choose between either increasing dose or adding fenofibrate or adding esters of omega fatty acid or any other category of drugs which are available, like for example, saroglitazar or something, with the patient with does residual CV risk in these cases changes, sir? So, what is your go-to drug in these patients with hypertriglyceridemia?
See, what we have to remember is that our first goal is LDL. Then comes a risk enhancing factor like triglyceride. So when we have achieved the LDL goal, but still we have associated hypertriglyceridemia, suppose it is more than 200 to 500, or furthermore, if it is more than 500, then there is a risk of pancreatitis. So first is lifestyle modification and dietary changes we suggest to the patient, and then we continue statin. And what I have seen, if I give statin alone, the triglyceride goes down to a certain level. But if I use a combination of statin plus azithromycin, it goes further down. Then the second drug which comes in is the fenofibrates. But with fenofibrate, we have to remember that it increases the chance of myopathy with a higher dose of statin. So we have to be very cautious with that. Now comes this omega-3 fatty acids, which we use ISEPUP or any other name, and by 2 gram BD we use. And also the saroglitazole is an excellent molecule, the Indian molecule. And if the patient is having a diabetic dyslipidemia, typical diabetic dyslipidemia with associated metabolic syndrome, uh, fatty liver, so saroglitazole is excellent drug for that.
So you would be interchangingly using based on the clinical settings, correct, sir?
Yeah,
Fenofibrate
clinical
or
setting. Yeah,
acetamide.
first is we continue statin with acetamide. There is we recommend a lifestyle modification, dietary changes, exercise, change in the dietary pattern. Then keeping the same dose of statin, we add a fenofibrate. If we have a higher dose of statin and fenofibrate, there is more chances of having this
Rhabdomatous.
myopathy related symptoms. And
Right.
patient is diabetic, so we directly go with the saroglitazole.
Sir, what is your viewpoint on PCSK9 inhibitors, sir?
See, PCSK9 inhibitor, what I've seen it is definitely when we don't achieve our LDL goal with all this oral drug available. And as we know, there are socio-economic issues in India. So PCSK9 is an excellent drug, but it comes a bit later. So especially
Because of
familial
the
hyper.
affordability. Is it because
Yeah, affordability. So familial hypercholesterolemia is the one, especially the homozygous one,
yeah,
where it is required because we are not going to achieve the LDL target.
with
So
the oral
familial
forms?
hypercholesterolemia, and if the patient is affording and we are not achieving the LDL target, and patient lands in an extreme risk category A or B, so we advise them on whosoever is affordable. We are very sure.
Right, sir. Thank you, sir. With this category, sir, I like to move to the most happening category, that is anti-diabetic agent with cardiovascular outcomes, sir. As
Mhm.
such, the when I use the term anti-diabetic agent, I believe that itself is wrong, because today these category of drugs are more used by cardiologists like you than a diabetic or endocrinologist. Which you would agree with me, sir. That's a
Definitely.
tough for sir. To start with that, sir, have SGLT2 inhibitors have meaningfully changed your management of your patients with established ACVD or heart failure with reduced ejection fraction?
Yeah, definitely.
Hmm.
Definitely. It is one of the pillars of HUFRUF. Definitely. It has changed my
Yes.
practice. During my residency in cardiology, the trial came, which was EMPA-REG. At that time, the empagliflozin was mainly for diabetic this thing, but it has also shown cardiovascular benefits also at that time. Then the landmark trial, the DAPA-HF trial came in, and it changed our perspective that it has become more of a
Cardio.
cardiovascular drug than rather than an anti-diabetic drug. So
Absolutely.
definitely, and even SGLT, this even GLP-1 analogs also with the same
Yes.
thing. With select CV outcome, what we have seen is it has got excellent cardiovascular benefits also, semaglutide. And even this thing, terzapatide, they are coming with a surmount CV outcome trial.
Hmm.
It is a 4 year, it is still on, so they will be coming with a data for a
Okay.
CV outcome.
Great, sir. Sir, actually, my second question, what I've written is basically for GLP-1 agonist only, sir.
Mm,
Since you have already answered that question, but
mm,
still I'll try to put it forward, sir.
mm.
Just the GLP-1 receptor agonist is uses in your practice. In which type of patient do you consider it, sir? Just because it is considered as an anti-obesity drug you're using to make the patient with morbid obesity lose weight, or definitely you feel that this category drug has got uh, class cardiovascular effect also, sir.
See, if we see, there is a very much chaos in the social media and in the market. It is more of promoting as a weight
Anti-obesity.
reducing drug, but but it is basically an anti-diabetic drug, and it has got its benefit with by reducing weight and even the CV outcomes. So, especially what I've seen, the mainly what I'll give you example that most of at least 10 to 15% of our hypertensive patient has the obstructive sleep apnea. They are overweight. We are keeping them on 3 drugs, 4 drugs. The BP, we are not able to achieve the target. So in those kind of subsets where weight reducing is also important, and we have a cardiovascular benefits also. And these are typically pre-diabetic or diabetic patients. So we hit three birds with a one stone with
Hmm.
this drug.
Yes,
So
sir. So, sir, the point is, as of now, one category has come, and terazeptide is going to be the next one, which is go. It might go off patent, but the time is little more. As you know, sir, it
yeah.
will be get
Mm,
going off patent after
mm,
2030 only, sir.
mm.
Sir, you mean to say, sir, this with SGLT2, which you would be using extensively, it has become
Mm.
generic. Now GLP-1 agonist. Sir, how do you view these new categories? How impactful to the overall cardiovascular management, sir?
Yeah, definitely. See, for a half puff patient, heart failure with a preserved ejection fraction.
Hmm.
Like for the half rough, we have four pillars, right? But half rough. But for half puff, even this the class 2A recommendation is for SGLT2 inhibitors and GLP-1 analogs. So definitely it is going to change the cardiovascular outcomes. But the only issue with this drug is the tolerability.
Hmm.
To achieve the maximum dose, to achieve the target dose, the tolerability is the one of the major issues, one of the major concerns, what I have seen.
Okay. You meant for GLP-1 agonist, sir, or
Yeah,
SGLT2?
GLP-1
Got it, sir. Sir, there is just from this background, sir, I move on to hypertension management. There is one particular communication I would like to ask you, sir. Sir, how do you incorporate home blood pressure monitoring and ambulatory blood pressure monitoring in your practice, sir? Is there any barriers that limit its use?
Yes, see, uh, whenever for a mask hypertension or for a white coat effect, uh, home BP monitoring or the ambulatory blood pressure monitoring plays an important role. The issue with the Indian patients are like because they are not everybody is well educated, well aware. So to get a home BP monitoring from them is a difficult one. So I
Hmm.
suggest them an ambulatory blood pressure monitoring. One of the technician goes and fixes the ABPM machine, and we get a whole data and we rely on that. But definitely, as a cost-effective home BP monitoring also plays an important role.
Yeah.
Definitely.
Right, sir. So, blood pressure monitoring, you are not averse to using it, but your only concern is whether the patients are knowledgeable enough to do that. Correct, sir?
Yeah, yeah, definitely.
And probably it has got to do with the socio-economic background.
Yeah.
And another would be the kind of devices they might be using, sir.
The kind of devices, how they are using, we have to train them.
Yeah,
Yeah, one of our assistant or they train them that they have to sit and how they have to check, how they have to put the hand, and they should not have uh, any caffeine containing drinks or tea or coffee at least 15 to 20 minutes prior. Everything we have to explain them.
that's a
Uh,
got it, sir. Thank you, sir. Sir, heart failure management. Already you spoke a lot about the four pillars of heart failure management, sir. Sir, what is your viewpoint on a combination of a torsemide with eflurane in heart failure with reduced ejection fraction? Is it becoming your preferred diuretic MRA pairing, sir? Do you
Aplerin. Yeah,
have?
definitely. See, initially cost was a this thing concern. So we used to use a spironolactone with torsemide. But at least 30% of the patient, especially male patient, comes with a gynecomastia.
Okay,
So
sir.
even with,
Sorry, sir. Is it even with eflurane they complain, sir?
no, no, it is very less.
Very less.
It is very less. So even if I put the patient on spironolactone plus torsemide, in a 6 month or a year, at least most of the patient they comes with a complaint of gynecomastia. So we have to switch them to this thing, aplerenone. And even the hyperkalemia, it is much lesser as compared to spironolactone with aplerenone.
Thank you, sir. Sir, another thing, sir, the concept of heart failure management starter kit with reduced ejection fraction. That is a co-packed combination of an SGLT2 inhibitor, ARNI, or a beta blocker like bisoprolol, which is the most happening beta blocker today, sir. It is gaining traction as a strategy for management of heart failure, especially on neurohumoral blockade, sir.
Hmm.
How do you see that, sir? This kind of polypill concept in heart failure management can be implemented, and what is your viewpoint on this kind of polypill concept, sir?
See, depends from drug to drug, like the pharmacokinetics and the pharmacodynamics of a drug. Like now we have a combination of ERNI with gliflozins.
Yes,
So
sir.
gliflozins are OD drugs, once a day drugs. We know that. So, but here, what we have to give twice a day when the combination is there. So, pharmacokinetics and pharmacodynamics of a drug is one concern. If we are going to achieve that with a combination, so it is a good thing in a country like in India where pill burden is a issue.
Yeah.
Patient comes कि डॉक्टर साहब मेरा बहुत सारे दवाइयाँ चालू है उसमें कम कर दो. The
True.
doctors who prescribe a lesser medicine is a good doctor
Yeah, very true,
in
sir.
the eyes of a patient.
True.
So even if you are giving the same medicine, but the number of pills are less. So you indirectly you become a good doctor, though you are prescribing the same medications.
Same medication. So the
But that combination should have the same effect as far as when we give in a
FDA.
separate form.
Understood, sir. Thank you, sir. Sir, we move from pharmacologically therapy management to patient education and adherence, which is the last category of my today's interview with you, sir. Sir, how well do you really your patient grasp the concept of lifelong therapy for chronic cardiac condition? And what is the single most common reason they self discontinue the medications?
See, first though, there is a face-to-face counseling with the patient. Like I'll give you the example. When we do angioplasty, the aspirin and ticagrelor is a must. So initially we keep the follow for 5 days. Then we ask them to come for 1 month, then every 2 or 3 months. So suppose there are five medications written. So sometimes what patient does is he haphazardly he takes two medicine, drops one medicine on his own. So what to each and every post-plastic patient of mine, what ask them or tell them or मैं ask my assistant to tell them कि जितना खाना जरूरी है उतना ये तीन मेडिसिन जरूरी है. एक टाइम आप खाना भूल जाओ लेकिन आप एस्पिरिन और टिकागिलोर आपको भूलना नहीं है, अदरवाइज योर स्टेंट विल गेट ब्लॉक and you will come with a MI to each and every patient. So
Okay.
face-to-face counseling is very important. If you're going to stop the medication, these are the adverse effect you are going to have. But once a year passes or 2 year, 3 year, 4 year down the line when the patient is on single antiplatelet and he is asymptomatic, so he become relaxed, the follow-up delays, sometimes they come after 3 months, sometimes after 6 months. So they keep on, missing the medicine. Sometimes they stop on their own. Not
Okay.
initially, but once a year or two when they become comfortable. So
Understood, sir.
what we have done in our setting is we have a list of our pool of our patients and we have a data. So we keep on calling them. Initially for post-plastic patient, initially for 3 months. You don't skip your medicine. If you have bleeding issues, come to us again. And
Understood.
then after 1 year, after when the patient is of heart failure, then we keep on calling again and asking them for a blood test and everything. So definitely face to face and keep a connection with the patient,
Got it,
either
sir.
on a phone or a WhatsApp group.
Got it, sir. Sir, one
Mm.
point which I accepted, sir, the face to face, which is a very valid point, that there is no substitution for
Yeah,
face
no,
to face counseling by
yeah,
a
definitely.
doctor,
Uh,
right? But in your busy practice of like someone like yours, sir, you will have a challenge in managing time for them. But I have
so for
understood from your session. Yeah, sorry, sir. Yeah. Yes, sir.
my priority first is my plastic patients. Whenever I do angioplasty, when I discharge them, I meet them personally and I explain them the discharge card personally.
Okay.
The way I explain, or maybe the patient is connected to me, even my assistant explain, it doesn't bring the same value to the patient. But once the message is conveyed for these, then later on, my assistant or our team, they coordinate with that. But the first interaction is very important.
Important. But for a busy
Um,
practitioner like you, sir,
uh,
the time is essence and
yeah,
value
time
for
is
you. How
there.
do you
So,
manage it?
yeah. So definitely the first, whenever I meet the patient at that time, and then again we start conveying with our team and WhatsApp messages.
Right, sir.
That
Yeah,
is
that
the,
was that
that is
was
the
the
practical approach.
approach.
But
Yes.
you have to spend time for your, patients. If they stop the medications, then we are going to have a very adverse outcome,
Great, sir.
uh,
Yeah, I understand. Sir,
especially heart failure patients and post-plastic patients.
yeah, very crucial subcategories
Mm.
where they need to have more of counseling and hand holding, I would say, sir. The hand holding would be very much important for the first 2 to 3 months. I think
You
which
have
you
to
have,
take time. We have
yeah,
to take time.
we have to take time. So to add on to that same point, sir, which patient education tool you find most effective in your practice, sir? Is it printed leaflets with regional languages, patient education booklet we call, videos? recorded videos from your side or whatever it is, WhatsApp messages, apps, or face-to-face counseling, which you have spoken a lot about it, sir. And one point which I would like to ask here is, sir, does the effectiveness of these patient education tools, do they differ by age group or literacy level of the patient, sir? What is your general viewpoint on
Yes,
this?
yeah, definitely. See, face to face is one,
Yes, sir.
but every time we can't do face to face. So we
Absolutely.
have for our patient we have a leaflets in the regional language. Like I practice in BND, so Hindi and Marathi and English.
English.
And there are instructions regarding exercise, regarding dietary patterns, regarding the medication. So this has, because not every patient of yours will see your video. A
Okay.
a homemaker lady who is not literate, whom you have done an angioplasty, and she's not going to see your Instagram profile or a podcast or a WhatsApp. So different forms affects a different zone of a people.
People
For
and age
youngster
group.
and educated people, podcast and WhatsApp messages, videos, they play a role.
Yeah.
But the language should be a simple in local language. Even if you are using English as a language medium, you have to use a simple so the people can understand.
Okay, sir.
So
It is
I practice all the ways. I try
all
all
the
the ways.
ways.
Face to face, leaflets. I do podcasts. I post reels.
Got
Whatever way is possible, we try to do. Because there is no one platform where the patient will connect to you.
it. Yeah.
There is
So we
not like a single platform.
right, sir. So
So you have to use
definitely
all the platforms in my
all
point, from my
so
point of view.
whatever I have told every platform to be used,
Yeah,
depending on the age group or literacy level, these
yeah,
are
yeah.
the things. Got it, sir. Sir,
Because we have a huge diversity in our population, whether it is socioeconomic status, in each and every segment, there is a huge diversity. So you have to hit the different platforms.
understood, sir.
That is
Thank you,
the
sir.
dictum.
Got it, sir. Sir, I think now I come to the concluding point of this wonderful interview what you gave, sir. The last half an hour have been very informative, very interactive, and I was able to read your mind. How do you manage your patients? How much steps you take to manage the conditions beautifully, sir. And as I summarize this entire interaction we had in the last half an hour, sir, one summary question I would like to ask you before I end this recording, sir.
Hmm.
Many new category of drugs have come in the last, let us say, 10 years.
Hmm.
A GLP-2 inhibitor, PCSK9 inhibitor, GLP-1 agonist, new antiplatelet drugs like ticagrelor, etc., etc. Sir. Out of this, if you have to choose one category, which you believe has profoundly changed your clinical practice, what is that one category you would choose, sir? Because this question I've been asking across the country to KOLs like you. So there is nothing right,
It is
nothing
difficult.
wrong. It's your viewpoint I would like to hear, sir.
It is difficult to use one drug.
Yes, sir.
See, it is difficult to choose one drug. I choose two. I'll tell
Uh,
you why.
okay, sir. Right.
As an interventional cardiologist, when we do angioplasty, our much concern is that the patient should not present with a stent thrombosis.
Hmm.
So we know that at least 30% of population is not responded to clopidogrel. So initially we had a lot of issue with the stent thrombosis before ticagrelor. Even the quality of stent also and the tica was not available. So now the quality of stent has improved, and with ticagrelor coming in, the incidence of
Then,
stent
then,
thrombosis has gone down. So we feel much relief with that. That is one.
okay. So
Okay. And then
your first vote goes to newer antiplatelet like ticagrelor, right, sir?
antiplatelet.
Okay.
Then and same with the anticoagulant also. Initially, we have to rely on vitamin K antagonist with PT-INR, which has a narrow therapeutic index. Now we have an OX. The second one is SGLT2 inhibitor.
Right, sir. So Arni is in the pegging order, so three only, third only.
Yeah, Arni is to there. Arni is there. Arni is since many much years. But before Arni, we have these ACE inhibitors also. No?
Mhm. Yes, sir. So still
So
you
they were also providing
the similar.
almost same result. But this SGLT2 inhibitors, When they came in, so again we have it is has got excellent with it is used in both half puff and diabetes both every so and even as a weight reducing agent also.
Yeah, I
It
understand, sir.
has got a BP reducing effect also.
Yeah, I understood, sir. So it's tough when you take a kid to a toy shop and ask it like you should choose one only. The kid
Uh,
would always ask that I would take at least two.
but I am very much happy with the newer antiplatelets. I'm much happy with the newer antiplatelets.
So still, so now we will go back to and say that this is the one category of drug which has profoundly changed your practice.
Mm.
So still the choice is yours, sir. I think I would respect your decision to vote for
Uh,
two drugs. One is antiplatelet and anticoagulant as one category, and as number two would be SGLT2, sir. Thank you, sir. Thanks for this wonderful evening and session, sir. I think very informative. I believe it will be used effectively as my team would be taking up to young, upcoming, budding cardiologists and PGs across the country because we have a platform called Cardio Next where I will be parking your video recording also for them to learn later in stages also, sir. And we will also share a link of this recording to you later once it get edited, sir. And thank you for the wonderful evening, sir. Thank you.
Thank you. It was a pleasure to interact with you, sir. Vignesh, sir. It was a pleasure. And definitely, I believe that it is going to help fellows of a cardiology.
100%. Without iota of doubt, I believe this is one of the best interview for this season I have taken, sir. Thank you very much. And have
Thank
a
you.
very good evening, sir.
Thank you.
Thank you.
Have
Thank
a
you.
good night. Thank you.
Thank you.